In an inferior MI, we generally have an occlusion of the RCA, the right coronary artery, and it will show up on the ECG as ST elevation in leads 2, leads 3, and AVF. In patients with an inferior MI, secondary to an RCA occlusion, so a right coronary artery occlusion, we'll see that in lead 3, we'll typically see greater ST elevation than lead 2. And that's because the ischemia is more generally in a rightwards direction. You'll also typically see reciprocal depression in the lateral leads, so leads 1 and AVL especially. On the other hand, an inferior MI secondary to occlusion of the other coronary arteries is possible because of the different variants in anatomy. Usually we'll see right dominant anatomy. That's the most common, and that's where the RCA gives rise to the PDA, the posterior descending artery, and also the left ventricular artery. But alternatively, in other circumstances, you can have a left dominant system where it will be the left circumflex artery that will represent the larger artery supplying the inferior wall. And then the other, as we discussed, was the wraparound or type 3 LAD. With the occlusion of the LCX, the left circumflex, which would usually give lateral ST elevation, we can sometimes see inferior ST elevation when we have a left dominant system. Looking at the inferior leads, we'll see that the ST elevation is greater in lead 2 than leads 3 and AVF. And the reciprocal changes that we saw when we had the occlusion of the RCA will be absent. Another thing to bear in mind with inferior MIs is that roughly a third of these patients will present with some degree of AV block, and this is because the AV nodal artery is a branch of the right system.